Hello, can you hear me?
I can.
Amazing.
Okay.
Perfect.
Awesome.
In that case, I will get set up. I'll just wait about another minute and then I'll get started. Okay. Let me just shift over my screen a little bit. Everyone can hear me?
I can certainly hear you.
Fantastic. Okay, great. So I am Shara Fitzgerald from the Geriatrics Division, and I will be presenting today's rounds on an area of great recent interest in our field, updates in Alzheimer's disease, biomarkers, and anti-amyloid therapies. I have no conflicts of interest, but I do want to disclose that I'm using aspects of my slides that I received from ESI purely for educational purposes and that it is not an endorsement of any specific drug. Our learning objectives for today are to review the pathophysiology and clinical presentation of Alzheimer's with a focus on the evolving biologic definition, to understand how biomarkers are used for diagnosis of Alzheimer's disease, and to recognize the development of anti-amyloid therapies and their evolving role in the treatment of patients with Alzheimer's. Let's start from the beginning. Dementia is a syndrome of acquired decline in one or more cognitive domains that is severe enough to interfere with independence to daily functioning. This image shows you the different cognitive domains that we assess through objective testing at bedside. And to be diagnosed with dementia, you need three components: subjective decline, objective impairment on testing, and progressive functional impairment. Dementia is a syndrome, not a disease. It is caused by a number of diseases, one of which is Alzheimer's. There are many other causes, including vascular dementia, Lewy body, frontotemporal, and many other rarer conditions. Many patients have mixed pathologies. That said, most people with dementia have some element of Alzheimer's pathology. Jumping back into the past for a moment, the first patient with Alzheimer's disease was identified in the late 1890s, Auguste Dieter. Dr. Alzheimer's described her clinical presentation as difficulty remembering events, changes in behavior, and problems with speaking and writing. She died in 1906, and on autopsy, her brain was identified to have significant atrophy with numerous waxy protein abnormal deposits. In 1968, we then were able to better characterize these as plaques and tangles. Over time, more and more cases were identified, and it becomes more clear that most cases of this disease follow a very predictable clinical presentation with early amnestic change and progressive loss of other domains of clinical function, leading to functional impairment and ultimately death. Until recently, Alzheimer's disease in practice has been a clinical diagnosis based on clinical criteria, which have evolved a little bit over the years but have remained largely unchanged in their essence since their development in the 80s. And here is a very busy slide that shows you an example of this diagnostic criteria from 2011, which was the most updated version until recently. And all I really want to point out here is that we're using clinical symptoms to make this diagnosis. They have visuospatial impairment, they have memory impairment, they're following a specific kind of pattern, and they don't have clinical criteria of other diseases. That's how we used to diagnose it. Dementia occurred on a 6-stage spectrum of cognitive impairment that begins with a normal presentation, which is the complete absence of both the disease and any symptoms. Stage 2 is subjective symptoms without objective findings on cognitive testing, called subjective cognitive impairment, or SCI. Stage 3 is mild cognitive impairment, which means there are subjective symptoms and impaired scores on cognitive testing, but without functional impairment. And then stages 4 to 6 are your mild, moderate, and severe dementia, respectively, as patients develop progressive levels of functional impairment. In 2024, revised diagnostic criteria was published by the Alzheimer's Association, and for the first time, the new criteria brought into the clinical sphere concepts that had been developing for decades in a research scope, which had led to, which we will talk about, the development of new drugs and potential new therapies for Alzheimer's. For the first time, the criteria emphasized that the disease should be diagnosed using neuropathological markers rather than clinical symptoms. We define Alzheimer's disease to be a biologic process that begins with the appearance of Alzheimer's neuropathologic change while people are asymptomatic, and that is a shift away from clinical symptoms to biomarkers. So let's talk about Alzheimer's biomarkers. To understand them, we first need to dive a little deeper into the neuropathology of the disease. We already discussed that the neuropathologic features of Alzheimer's are plaques and tangles. If you look at an Alzheimer's brain compared to a healthy brain, you will see accumulation of these plaques and tangles, particularly in the temporal and frontal cortex. The accumulation starts decades before symptoms arise in a predictable pattern across the brain that is described by something called Braak staging, which I will not get into. Further downstream, you will then have other brain changes, including inflammatory cell activation, vascular changes, and oxidative stress damage, all of which are thought to contribute downstream to symptoms. So how do the plaques and tangles accumulate? Plaques are made of amyloid, which is a naturally occurring protein in the brain that gets misfolded and then sticks to itself to cause a bunch of problems. Amyloid starts off as little pieces of a much larger protein complex in the nerve cell membrane called the amyloid precursor protein, or APP. In healthy cell homeostasis, these little amyloid pieces are cleaved off APP, and then they are supposed to be cleared by a variety of mechanisms in the brain. In a healthy human, you will have a nice balance of production and clearance of these amyloid bits, but in Alzheimer's, there's an imbalance in amyloid production and clearance, and I've heard from experts in the field that it only takes an imbalance of about 10% overall before you start to develop this slow accumulation over the decades. And this is just showing you how the APP sits in the cell membrane. The enzyme complex cleaves it off, and then bits of amyloid start floating around. They start off as monomers, but unfortunately, amyloid is very chemically sticky. So instead of staying small, they find each other and they build into oligomers and then later into fibrils until they form amyloid plaques. What about tau? So what about tangles? Tangles are made of tau, which is a totally different protein. Healthy tau is part of the nerve cell's skeleton, stabilizing microtubules. But under stressful conditions, tau will go down this bad pathway called hyperphosphorylation, which then causes it to detach from the skeleton, misfold itself, and become sticky. When lots of tau does this, it accumulates into neurofibrillary tangles. These tangles are directly and indirectly neurotoxic and lead to cell death. Tauopathy occurs in a great many diseases, not just Alzheimer's, including things like frontotemporal dementia and several related atypical Parkinsonism disorders, but it also occurs in Alzheimer's. So how does this all come together in Alzheimer's disease? Well, on one hand, you have this theory of how amyloid plaques form, and on the other hand, you have this theory of how tau neurofibrillary tangles form. And the unifying theory is that in Alzheimer's disease, the amyloid pathway triggers the tau pathway. So it's believed that Alzheimer's disease is basically a tauopathy triggered by amyloid aggregation. We think that amyloid plaques cause phosphorylation of tau by disrupting cell signaling, increasing neuroinflammation, and increasing oxidative stress. The new diagnostic criteria for Alzheimer's proposes a biomarker classification system called the ATN framework that addresses these aspects we just discussed: amyloid, tau, and the resulting cell death called neurodegeneration. A lot of research has gone into the best specific versions of amyloid and tau to measure which reliably correlate with disease presentation. In practice, there are three main ways that we measure these: through imaging, via CSF, and in plasma. The things that we are measuring are the biomarkers of Alzheimer's. Here are the most commonly used biomarkers in Alzheimer's, shown grouped by if they measure amyloid, tau, or neurodegeneration, and then if it's measured by CSF, plasma, or imaging. I've highlighted the biomarkers that are most commonly measured in clinical practice rather than research. The gold standard is your amyloid PET scan, where a tracer is used to light up the buildup of amyloid in the brain. The other biomarkers are often compared to amyloid PET scans to validate them. Another common ratio is the amyloid 42/40 ratio, which is basically measuring bad sticky amyloid compared to normal amyloid. And since in Alzheimer's, the sticky amyloid gets used up and turned into plaques, the ratio is then lowering in the disease rather than healthy controls. And then finally, you have various measures of p-tau, or phosphorylated tau, which increases in concentration in CSF and blood. And so the idea is that in the ATN model, patients get tested for each of these categories using one or more of the biomarkers, and then they're classified as A positive, T positive, or N positive, respectively. Respectively. So you get an A positive or negative, a T positive or negative, and an N positive or negative. And then once you've established if someone is positive or negative for each component, you then get their ATN profile by combining all three. So say that you have someone positive for amyloid, positive for tau, and positive for neurodegeneration, which is the profile that's shown here by the red arrow. That person has pathologic Alzheimer's disease. You can see that if you kind of extend through, they fit into the Alzheimer's continuum, and they most likely have Alzheimer's disease. The rest of the profiles vary based on your specific combination of these positive and negative biomarkers. Some were very clear about what it means. For example, if you have negative A, negative T, negative N, that's normal. But some, which are kind of in the middle, you're positive for something, you're negative for others, are not as clear and are still being evaluated and figured out. Okay, so you may be wondering, taking a slight detour, where MRIs fit into this picture, because I have not mentioned them as part of the biomarkers of Alzheimer's. And especially because this is something that the geriatric service often recommends. Now, I will say that when we're on consult service, we're usually ordering MRI heads for a completely different reason that has nothing to do with Alzheimer's testing. Usually, it's either because people's cognitive symptoms have progressed more quickly than expected for typical dementia, and we want to ensure that there's no reversible process going on, like Dr. Nam spoke about in detail at her rounds last year. Or somebody has a delirium that is lasting a very long time, not resolving the way we would expect it to, and we want to understand if there's an acute event causing sustained impairment. So that use of MRI head is very different and much more urgent than the use of this version, which would be something helping us and advising us on the pathology, etiology of someone's dementia. But it does have a role in this as well, and the highest authority in Canada on dementia diagnosis is the Canadian Consensus Conference criteria, which recommends that even in older adults, neuroimaging should be done in most situations, and here is a list of all the things that you should do it for, and specifically recommends that MRI is preferable over CT because of the various different levels of more information that it gives us. In this situation, we're looking for atrophy patterns, which is a manifestation of the N, or neurodegeneration, part of that ATN model. And so atrophy can happen in the Alzheimer's pattern, which affects the medial and parietal lobes first, or it can occur in a different pattern, for example, more frontal, which would be more frontotemporal, or various other different patterns. And then we're also looking for features of vascular disease, something structural, intracranial pathology, a whole host of other things. And so because MRIs shed light on a variety of diagnoses, Alzheimer's biomarker testing will not replace the need for MRIs, especially if you're not sure what the diagnosis is in patients with cognitive impairment. But they still do change the landscape of the disease in some ways. And so one of the most significant implications is that we can now, in theory, detect Alzheimer's even before clinical symptoms because biomarkers accumulate years before the disease actually demonstrates symptoms. So that raises this new possibility of a preclinical stage 0 of Alzheimer's. And so if you look at this graph with axis being time and the accumulation of the pattern of which biomarker rises at what time, you can see that several of them cross the detection threshold well before you start to even have MCI. So that is interesting, but there are definitely some big caveats to this use right now. And so first, access to testing is not as widely available or standardized in quality as we would like. And secondly, and most importantly, we don't fully understand how predictive the different biomarker profiles are. So a cognitively asymptomatic 75-year-old has a 40% likelihood of a positive amyloid scan, PET scan, and that's a pretty high likelihood. And they also have a 15% chance of both amyloid and tau being positive without any symptoms. But we still don't really understand what chance it is that this person will develop clinically significant disease, nor when, if ever, that will actually happen. And so for this reason, because even though we have this concept of a preclinical stage 0 Alzheimer's patient, our current biomarker understanding doesn't allow us to confidently diagnose this. And so the recommendation is against the use of Alzheimer's biomarkers in asymptomatic patients. The limitation of the available gold standard biomarkers has made us all very excited to some degree about the recent commercial availability of blood-based biomarkers, which are now available out of pocket from labs like Life Labs and Dynacare. The issue with this is the standardization of quality. None of them are Health Canada approved as yet for this reason, and this severely impacts their usefulness right now. So for example, we talked about this ratio, which should help us rule out the disease because the amyloid ratio is very sensitive. But the assay is very unreliable right now, which means you're getting a lot of false negatives, which means it's actually not that helpful to rule out the disease until it's got some higher quality. Similarly, p-tau217 is very sensitive, but it's not very specific. And so it shows up in a lot of different patients like sarcopenic patients, patients with ALS. And so it can potentially help you confirm the disease, but it can't help you rule it out. And lots of people want to use these biomarkers to help give them the peace of mind that they don't have Alzheimer's, except that's not actually how they can be used right now. So the current recommendation is that we can use p-tau217 as a sensitive but not specific marker for Alzheimer's in symptomatic patients only to help confirm the diagnosis. But even still, if you were going to go the step further and, for example, use a therapy that we will talk about, you still need some other gold standard biomarker to confirm it. You can't just use the blood biomarkers. Okay, so if we can't use the biomarkers for so many different things, then what do we use them for? And basically there's two situations. One is if you have a patient who wants confirmation of Alzheimer's, who is symptomatic and who follows the clinical presentation that makes you very suspicious they have Alzheimer's, then yes, you can use these biomarkers to confirm that diagnosis. And then secondly, you can also use them for consideration of amyloid targeting therapies, which we will now discuss. So for the rest of this talk, I will be discussing amyloid targeting therapies, which have been getting a lot of press over the past 2 years as a potential cure for Alzheimer's, which I will just say off the bat that they are not. I believe that it was Dr. Friedland who also presented some information about one of the earlier drugs in this space a few years ago called aducanumab, which has since been discontinued. But these drugs are here to stay, and for the first time in Canada, we approved one last year called lecanemab. Amyloid targeting therapies are an answer to the amyloid cascade hypothesis. The idea is that if amyloid is the upstream trigger of neurodegeneration and symptoms, then removing it might prevent the clinical manifestations of this disease. They are monoclonal antibodies that bind to amyloid in the brain, tag them for clearance by the immune system, and reduce amyloid plaque burden. Here you can see the names of the drugs that exist and are in development, and all I want you to see is that they are all working on the amyloid cascade at various different levels across the accumulation pathway. And I've highlighted here the two that we'll be talking about today, lecanemab and donanemab, and you can see they don't act at the same place, but they're all acting on the pathway. So lecanemab is the first anti-amyloid targeted therapy to be approved by Health Canada. It occurred in fall 2025. It works by clearing the soluble amyloid protofibrils from the brain with the intention of reducing amyloid plaque buildup. It was designed to be initiated either during the MCI or mild dementia phase of Alzheimer's disease, so quite early in the process. Patients who are in the moderate and severe stages are not candidates. And in the trial, the main trial, this corresponded to an MMSE score of 22 or higher, just to give you a sense of how well they're performing. The phase 3 trial for lecanemab is called Clarity AD, published in 2023. It was an 18-month phase 3 global double-blind placebo-controlled study evaluating the drug in 1795 patients with early Alzheimer's disease. The medication was administered at a dose of 10 milligrams per kilogram as a biweekly IV infusion. The trial then underwent an open-label extension for a total of 48 months, during which patients could voluntarily continue with either biweekly or monthly infusions, and there was also a subset of patients who transitioned to a weekly subcutaneous autoinjector similar to semaglutide. Clarity AD included adults aged 50 to 90 with early Alzheimer's disease, defined as having both objective memory impairment on cognitive testing and confirmed amyloid pathology via PET or CSF. As I mentioned, this included an MMSE score of 22 to 30, and then they also used this different score called CDR, and you needed a rating of 0.5 to 1. And then additionally, they needed to have a very well-involved family member, caregiver, informant available, which of course narrows down the people that can participate in a trial. Notably, which was great, patients were allowed to be on pre-existing Alzheimer's medications. So cholinesterase inhibitors, memantine, you could be on those, but you had to be on a stable dose for at least 12 weeks prior to your enrollment. Now, there was, of course, quite clear exclusion criteria, and that included any reason that you wouldn't be able to get an MRI, any coexisting depression with a GDS score of 8 or higher, and any known coexisting dementia pathology for obvious reasons, including vascular history. And so regarding your vascular diagnoses, any person with a history of TIA, stroke, or seizure within 12 months was an exclusion criteria. And then there was also neuropathological criteria due to the risk of intracranial bleeding from the medication. And so this included any suggestive findings of CAA, cerebral amyloid angiopathy, such as a hemorrhage of over 1 centimeter large, or 4 microhemorrhages or AV malformations. The trial's primary outcome was the change in a specific cognitive score called the CDR sum of boxes from baseline to 18 months. But they also used a bunch of other scales measuring cognition, function, caregiver burden, and they measured radiographic and CSF burden of amyloid and tau. Let's talk a little bit about the CDR sum of boxes because it's not a scale that is commonly used in clinical practice. It's a research tool. You may not be familiar with it, and certainly that would be very expected, but you might be familiar with the MoCA and the MMSE, which are screening tools for cognitive impairment that we use in clinical practice. These test for cognitive domains, but they don't include a functional aspect in the score itself, meaning how you do on your finances or whether you miss your medications, none of that is actually factored into the score. So you don't actually get a stage of your dementia because, as we mentioned, you need to have subjective, objective, and functional impairment to actually stage your dementia. So the CDR sum of boxes is sort of the research world's way of quantifying this whole thing into a number. And so it has both cognitive and functional aspects. The score goes from 0 to 18, with 0 being normal and 18 being the most advanced form of dementia. Now, there's a few reasons why this score is difficult to interpret. For one, people with Alzheimer's do not progress through the disease at the same rate, and so they spend a lot of time in the initial earlier scores rather than later scores. So for that reason, the scale is considered nonlinear, and when tracking change, it's a little bit hard to do it. Why is that important? Because basically the argument is that very small changes in the score at early stages means a lot more than change at a later stage. And so in the stage of Alzheimer's that this trial looks at, patients progress an average of 1 to 2 points per year. And so some argue that measuring change is difficult in this sort of shortened time period. Okay, so let's talk about the results. Here are the baseline characteristics of the full population, and then Eisai has also given us some Canada-specific data, which is very similar. Demographically, the age and gender proportions look even, and patients were evenly split between MCI versus mild dementia in lecanemab and placebo groups, which is great. On average, patients had a CDR score of 3.2 at the starting line of the trial. So what did the trial show? Let's start with the graph showing the secondary outcome of amyloid removal from the brain. And the reason that I'm doing this is because I want to show you that the drug does what it says it will do, which is remove amyloid. The black line shows amyloid in the placebo group over time, and the green line shows the amyloid burden in patients who received the drug. You can clearly see that there's a very significant reduction of amyloid burden over the 18 months. So the drug did what it said it would do. It removed the amyloid. But does it show an actual clinical outcome? So the primary outcome, CDR sum of boxes, this is the change that there was. Over 18 months, the patients on lecanemab did progress more slowly than their placebo counterparts. Green is lecanemab and black is the placebo. The total difference in score in progression in the Canadian population, which is shown in this graph, was 0.58 points. And in the whole trial population was 0.45 points. This translates to a slowing of 27%. The result was highly statistically significant with a p-value of less than 0.00001. But to interpret the clinical significance of this difference, we need to consider what the minimally clinically important difference is on the scale. And unfortunately, we don't actually know this with complete confidence. There have been attempts to establish it, and the most commonly cited is this rapid review from 2023. The review found that many studies have looked at this previously. They found a clear signal that smaller differences were more significant at earlier stages in the disease, as we suspected, and they ultimately concluded that the difference of around 1 point or greater was probably significant. The difference in this trial, remember, was that 0.58 or 0.45 points over 18 months. Other groups in slightly different ways, and they concluded that perhaps this was undercalled and actually the significant difference was more like 0.5 to 1. I take these with a bit of a grain of salt because many of these articles were published after lecanemab came out, so the point is that we don't really have full significance. Okay, so when Clarity AD was the only data we had and we didn't have anything else, many of us felt very conflicted about this drug. We didn't necessarily feel confident that lecanemab was in fact clinically effective. And if it was certainly not a very prominent dramatic effect. Last year, Eisai published data from the open label extension at the International Alzheimer's Conference held here in Toronto. And this data is a little bit more promising. So a very large proportion of the people that were in the original study continued on to the open label extension, and they kind of dropped off for various reasons slowly over time, but in the end about 478 patients were still receiving treatment after 4 years. And so the issue with this part of the trial is that there's no real placebo group for the extension phase. And so the company drew on these pre-existing large-scale cohorts to find observational data on what the expected rate of decline for a placebo group would be. They used 3 different matched cohorts, and if anybody cares, I'm happy to give you more information on why that was and why they used 3 different cohorts. But ultimately, they were just trying to show different ways of expecting the level of progression, and they found these 3 as an example. Ultimately, what you can see with blue being the lecanemab and then the cohorts being the other colors is that there is a sustained slowing at nearly the same rate over the next 3 years. So it continues at 27% for 3 years. And then in that last cohort, if you look, there's sort of like one cohort that's a little bit different than the other ones. And the most conservative difference is about 19%. And the other cohorts, it's again that same sort of 27, 28 change. And so this data kind of shifted my own perspective on this medication, because at least you are seeing some kind of sustained ongoing slowing over the course of multiple years, which, even though we know that, that first 18 months, the minimal clinical significance may not have actually shown, you're certainly crossing over into that territory at this point. You're certainly going to start seeing some separation in functional and demonstrable significance by this point. So do you call that working? Yes, I call that working. It's not a cure, but it does modestly slow down progression. On the order, a way to think of it is basically a few months per year of treatment. It's more than we had to offer before, and this is the first time in decades that we've actually had something else to offer our patients other than the pre-existing treatments. And what's good about this is that it's also additive on top of what we were previously seeing from our previous treatments. So now we have something kind of new to offer. That said, of course, I want to acknowledge that depending on your own belief about the data and whether you think that 18 months is required or you actually need to stay on it longer to see a difference, that's a lot of time invested for perhaps a modest benefit. And of course, the biggest limitation is cost. And so right now, that cost is a staggering 35 to 40K for the first 18 months. And that is not currently covered in Canada and is, of course, simply not realistic for most patients. Let's now talk about the risks of the drug, since that was not enough bad news. So first of all, patients can develop infusion reactions, which occurs in approximately a quarter of our patients, and as with any other drug, has a variety of different levels of reaction. In extreme cases, those reactions can actually require admission for management of severe allergic reactions, as with any drug, as I was saying. The main risk of this unique medication is ARIA. And ARIA is treatment-related amyloid-related imaging abnormalities. It is euphemistically called imaging abnormalities, but they absolutely do translate to clinical symptoms in some patients. The findings necessitate regular MRI monitoring throughout the treatment protocol. They are most likely to show up within the first 3 months of treatment, and especially most common after the first month. The mechanisms leading to this are not fully understood, but are thought to be related to increased vascular permeability that is triggered by the removal of the parenchymal or vascular amyloid. There are 2 flavors to ARIA, E or edematous changes and H or hemorrhagic changes, and you can see here how they appear on an MRI. As I said, they are not just imaging-related abnormalities. They do and can certainly translate to symptoms, and so they can have effects such as headache, confusion, behavioral changes, and nausea. And then a smaller subset of patients will also have gait disturbances and visual disturbances, and in most severe cases, patients can actually develop focal neurologic deficits and seizures. How common is it? Well, the one thing we definitely know is that it is much more common with the drug than with placebo. The total risk in the Clarity AD was 21% for Leqembi and 9% in the placebo group, including all the asymptomatic events. But my personal opinion about asymptomatic events is that they shouldn't really be disregarded. Like, we simply don't have longitudinal data right now to understand the consequence of these white matter changes that have shown up on imaging. And A lot of the time in our patients, when they have cognitive symptoms that we don't know how to explain, and you look at their scan and you see white matter changes, you do feel that there is some correlation. And so we don't really know what this is going to mean kind of downstream in the future. Um, it is worth noting that the risk of ARIA is much higher in patients with the genetic profile of ApoE4 homozygosity. And ApoE, for those that don't know, is a gene that is associated with increased Alzheimer's risk itself. And when you're homozygous, you're at a very increased risk of having the disease. Patients with this profile are 3 times as likely to get ARIA, and they were included in the trial. So quite a few people with the trial did have ApoE homozygosity. When they separated out these groups, basically what they found is that it's about 3 times as high of a rate, and 3% of people with ApoE4 had serious events from ARIA, and 1% of people who didn't had serious events from ARIA. And then the risk of ICH was about 0.5 in the non-ApoE homozygotes and 0.7 in the extension phase. In light of ARIA, we now have appropriate use recommendations from practice leaders with some specific guidelines on who should and should not be offered this drug. They recommend against use if people are on anticoagulation. Aspirin is fine. Secondly, people who are on lecanemab cannot be treated with acute thrombolytics, and the drug company is currently making sure that everybody has a card to ensure that they alert hospitals, but they're also talking about a bracelet. This is obviously something very important. When we start to use this drug, everybody needs to know that they are taking it. How do we manage ARIA? We have some protocols, again, developed by our appropriate use recommendations. This is just an example of the pathway, which helps to determine if someone should have that drug suspended or discontinued, depending on the severity of their presentation. And again, this is kind of similar. It's based on symptoms from no symptoms to severe and what the actual change and the extent of the radiographic change. And basically, most variations of this is that you will suspend dosing, you will do a repeat monitoring scan, and then you will restart the drug, hopefully. But of course, with the small subset of people who have a very severe reaction, that requires significantly different management, and it requires immediate action. And we don't actually have consensus right now on how this should be managed, but the thought is that ARIA may benefit from the use of corticosteroids as vascular stabilization in the same way that it can help with CAA events like cerebral amyloid angiopathy inflammatory events. The recommended course is 3 to 5 days of IV methylprednisone followed by oral prednisone, with some people and some case studies also including Plex. And so this would, of course, necessitate admission to hospital, and therefore something we would need to figure out a very clear pathway for if, as an institution, we plan on offering this medication. Given the risks of ARIA, you must do regular MRI monitoring throughout the protocol, and it's recommended before treatment initiation and prior to the 3rd, 5th, 7th, and 14th dose. That is a lot of MRIs, and that is very resource limiting. And so this is a rate limiting step for essentially every institution right now offering this medication. And so work is being done to standardize a shortened sequence for monitoring scans, particularly out of Calgary right now. And there isn't anything that's been released formally, but there's been some exploratory articles published by some practice leaders in Canada. And the thought is that we would only need a flare sequence and 1 susceptibility sequence for adequate detection. And so that protocol is a shortened protocol that only takes about 10 minutes and is a little bit more feasible given the sheer burden of MRIs that we would need to do. That is basically the drug itself and what is required to administer it. Practically speaking, from the perspective of Canadian implementation, Health Canada has officially approved this drug for use in MCI and mild Alzheimer's dementia. And over the past 6 months, the Canada Drug Agency had been preparing a recommendation as to whether it should be covered. And in March, they made the formal recommendation that it should not. Why did they say this? So basically, it came down to the minimally clinical significant difference that we were talking about. They decided that they were going to use a 0.5 cutoff, and as we discussed, that's actually a pretty generous cutoff because some of the other reviews say 1 to 2 points. And they ultimately said that for the trial itself, that 18-month period, the confidence interval crossed over, and so they didn't feel confident that it actually had that extent of change, which I think makes sense and is valid. They also looked at the longitudinal data, but they essentially said that although they acknowledged that the demonstrated difference was greater than the minimally clinical significant change, they didn't really feel it was a legitimate trial because there was no actual comparison placebo group, and the published data to date lacked methodological detail in the matching procedure with the cohorts. So it's not that they said that it was invalid, but they said they didn't have enough information to prove that it was a real convincing difference. And so at this point, the drug reviews they've opened it up for feedback, and that recently closed at the end of March. And so they haven't published a final result yet. So stay tuned. But maybe they will not change their recommendation, and then individual provinces will all then go through and make their own decision about whether to cover this or not. Okay, so before I wrap up, I just wanted to quickly demonstrate that lecanemab is by no means the only drug out there, and that there are several others in the pipeline right behind it. And so donanemab is a similar amyloid targeting therapy that, as I kind of alluded to before, targets the plaques instead of the protofibrils. And there is already a phase 3 trial for donanemab. All I want to point out here is that even though they used a slightly different scale and the starting cohort was slightly more progressed than that of lecanemab, the results are showing a very similar level of slowing of about 22.3% on the specific scale that they decided to use for their trial. They also used the CDR sum of boxes as a secondary outcome, which, as you may recall, is the exact same scale that was used for lecanemab. And it, again, shows a very comparable 28.9% slowing. So so far, we've had these multiple drugs with the same mechanism that are fantastic at actually getting rid of amyloid, show us that basically translates to about 28% slowing. And I expect that we will see similar drugs with a similar level of efficacy if they're able to do the same thing. And I think this is something that will kind of stick around, and we'll have hopefully better and safer iterations that have less ARIA, but will probably have a similar level of efficacy. These are far from the last drugs that will emerge in the space. The development pipeline is alive and well, and every year they publish 1 million different compounds that they're currently looking at. In particular, down the line, I expect to see a combined therapy that targets amyloid and tau, probably within the next decade, based on what I've been reading over the past years. And then we also know that an anti-amyloid injectable has been approved. That's basically like a semaglutide style version of this. It's being used as a maintenance right now, not as the actual initial dosing. But eventually, that will probably also exist. Okay, so next steps for SHN that I can leave you with. ATTs are not a cure, but they are here to stay, and they offer a modest slowing of progression, which patients may decide is worth it to them. They offer a chance to stay in the mildest stages of this disease for longer. No one knows better than an inpatient hospitalist or a consultant the devastating consequences of having moderate to severe dementia on your quality of life and on any other aspect of any healthcare that you are trying to administer and receive. So all we can do at this point is try to slow down the progression towards that stage. We can't do anything really when people get to that stage. So therefore, I advocate that there's a role for ATTs in the right patient, and that any institution offering gold standard dementia care needs to have the ability to offer them. Our institution has an excellent foundation on which to build. We have an established geriatrics and neurology division. We have a highly in-need population, and we have active infrastructure currently for outpatient and inpatient geriatric care. So our next steps would be to create a pathway for appropriate patient selection, which is a healthy, non-frail MCI and mild dementia patient, and then develop a robust pathway for those people. And so I look forward to seeing where we go from here. And that is my talk. So I will stop sharing my screen and I welcome any questions. Thank you so much. Yep, go ahead. Sada?
I don't have specific question. I think it's a fabulous and very timely talk. Thank you, Shara. It's amazing. I just wanted to reiterate one of the points, actually one of the points on the very last slide. because the scale for the Panama trial, or CDR scale actually, which does include points on functional status, as you said, and because the difference in CDR was found 1.8 approximately at 4 years, it practically means that 1/3 more of the patients remained at mild dementia stage at 4 years, which is completely different outcome than 1 to 2 points or 3 points on MMSE or MOCA or whatever other non-functional tests which we have, which I think by far is the best outcome from whatever we've seen before. So this medication offers a chance to our patients to remain at mild dementia stage 4 years in the disease. And we all know that this doesn't really happen very often anyway. With
Completely agree. Absolutely.
All. Thank you. Awesome. I probably would just add that we are hoping to have discussion with our radiology colleagues down the road to see whether or not, from radiology standpoint, from MRI standpoint, whether or not these medications could be, we could refer our patients to SHN to have this MRI.
Yeah.
We'll have to look for, some other resources.
Yep. Great. Okay, well, I will hang around for questions, but otherwise, have a great rest of your day, everyone. All right. See you later.